Hey guys, this is Dr. Rishi Desai from Osmosis. I'm the Chief Medical Officer, and I wanted to talk to you because of my background. I'm an infectious disease specialist. I did pediatric infectious disease, and then took a turn in my career and worked at the CDC. I was at the Division of Viral Diseases, and my role there was that I would actually go out. They would have me work on investigating outbreaks, so kind of like COVID-19, other outbreaks of viral diseases, and so that's what I focused on. And so for me, COVID-19 is a confluence of a lot of my personal interests and also is a public health issue that obviously is raging right now. So, infectious diseases, public health, outbreaks, education, health, all these kind of things are really what I care about. And so this is very personal to me. And I wanted to make sure we got really good information out there to make sure that we aren't kind of overreacting to this or underreacting to this, but really reacting, I think, in the best possible way, which is to be aware of the facts and not kind of getting misled by missteps. So that's the premise. What I wanted to do is also just point out that we will be answering questions. The whole point of this is to make this as interactive as possible. We got tons of questions already, so I actually framed up a bunch of answers for questions that I've already received. But if I see a bunch of questions or if you have a follow-up on a question, please post it. We're going to try to address that. And stay really closely connected with us because we're going to be dropping other videos. I'm going to mention a couple already to give those kind of good pieces of knowledge that you need right now to feel comfortable, feel like you're fully armed and ready to tackle this and kind of manage this and meet it head on. So that's the idea. Want to make sure that you engage as much as possible, and I'll try to do my best to answer all the questions. So with no further ado, I wanted to jump in with just some background information. So COVID-19, we know, started back in December of 2019. So it's been around for 3 months or so. All of the data we have is really just for this 3 months. So we don't have the full picture yet. And this will come up a few times in my presentation in terms of the data we're looking at. So let's start with the hard numbers. WHO reports that we have currently about 98,000 people that have been diagnosed with COVID-19. Of those, 3,400 have died. And so that's where they get this mortality rate of 3.4%. It's not mentioned much, but about 54,000 people have recovered. So they've gotten COVID-19 and now they're on the other end of it where they're feeling better and feeling kind of back to normal again. Those are just some quick hard numbers. What we're seeing, at least what I'm seeing on the ground here, is schools are wondering, when do we need to decide if we need to shut down? Employers are wondering what they need to do to help deal with the fact that many employees are staying at home, don't want to come to work, can't come to work. And some of that is because those employees are taking care of dependents, right? So many of those employees have kids in daycare, and if those kids aren't able to go to school because the daycare is shut, now the employer can't or the employee can't go to work. And so it's kind of this domino effect that's happening. We're also seeing conferences shut down, travel that's shutting down. So all across the board, you're seeing society affected in lots and lots of different ways. And then you see all this nefarious activity too. So you see hoarding of face masks and food. And on the flip side, you see people saying, well, if you're going to hoard, we're going to price gouge you. We're just going to jack up the prices, make it harder for others to get these very needed items during this outbreak. So these are all the things that we're seeing on the ground right now. And in this context, we've gotten a lot of questions. So I just want to, again, say I've tried to organize these questions as best as possible. But if I don't answer something specific, please come back at me and say, hey, what about such and such? So starting out, what is the case fatality? This is the first question. What is the case fatality rate? I'm hearing lots of different numbers. Great question. So the case fatality rate, according to the WHO, is 3.4%. And I mentioned the numbers, right? So the numerator, the top number, is the number of people that have died. It's a really easy number to be concrete about because you can count the dead bodies. And you can say, look, there are about 3,400 dead bodies that we see. That's the numerator. You're probably not missing a lot. The denominator is where things get really squishy. And that's why different people have different estimates on the case fatality rate. The official rate is, well, how many people have been diagnosed? And on that basis, we've diagnosed about 98,000 people. So if you just do the math, 3,400 into 98,000 is roughly 3.4%. So that's the WHO number. That's where they're getting it from. But here's the big thing with this outbreak and many outbreaks is that early on in an outbreak, what happens? You test the people that are severely sick, right? You're not going out and testing random people on the street for this disease. Why would you do that? And so if that's the case, you're missing a lot of people that actually do have COVID-19, but maybe they're asymptomatic. Or maybe they're so mildly ill, they don't even think about it. Maybe they thought, oh, it's just a runny nose, but actually they had COVID-19. So if you start testing more, in all likelihood, you would find a lot more. And if you found more, that denominator gets big and that whole percentage falls. So in South Korea, where they've done an incredible job of testing, they've done these kind of mobile clinics that were set up to test people while they're driving. They've literally blanketed everyone with PCR tests. They found a case fatality rate of 0.6%. 0.6, so far lower than 3.4%. And this is where they're testing everybody. The Diamond Princess cruise ship, where it's kind of a trapped population, you're testing everybody, there the case fatality rate was 0.9%. So again, it's a little higher than South Korea, but kind of in the ballpark. Both those numbers are below 1%. So this is why people are saying, oh, we think that the case fatality rate is closer to 1 or below 1. That's what it's based on. But again, technically, it's, if you actually go by the official data, it's 3.4%. Comparing this to flu is about 0.1%. So even if, and this is kind of me playing devil's advocate here, even if the case fatality rate was, let's say, 0.6 or 0.9, that's still 6 to 9 times bigger than the regular flu in terms of fatality. So it's still a pretty serious illness. But I just want to point that out, is that that's why these numbers are varying so much. So great question. Next question, what is the R naught? And the person obviously knows a little bit about this, because they say if it's over 2, which it is, then how come we're seeing fewer cases out of China? Now think about this. If you're saying R naught is 2, that means that it's doubling, right? 1 goes to 2, 2 goes to 4, 4 goes to 8. If that's the R naught, then how would we ever see that the numbers are going down, which they are in China? Well, this is basically understanding what R naught means. R naught is kind of the natural state of the virus, or any pathogen. So measles, the natural state is kind of an R naught of 12 to 18. One person has measles, let's say I have measles, that means that person on the other side of the room is likely to get measles. It's just very, very easily transmitted. So, but not everyone in the globe has measles, right? Like that would have happened many, many centuries ago if that was the case. That has not happened because of the fact that we have other methods of kind of combating that. So, for example, quarantine, contact tracing, good hygiene, washing your hands, not touching your face, making sure the sick people basically stay away from the healthy people. And also people get over the disease and then they are now no longer susceptible, right? So they become immune. So once you're immune, you're no longer susceptible to the disease and now you're kind of over it. So this is what we have to think about, is that it is pretty transmissible, R naught of 2.3, compared to flu, which is kind of like 1.3. It's quite transmissible, right, by comparison. But again, there are things you can do to combat that. And that's what we saw in China, is that China basically, very draconian, but kind of shut down entire cities and said, hey, we're going to keep people very, very separated here to combat this R naught of 2.3. So that's the reason. Next question. What's the incubation period? All right, so this is the period of time between you getting a sickness and you getting the symptoms. It's about 5 days median. We've seen data points up to 24 days, so it could be quite extreme. The CDC and WHO have kind of settled on 14 days being what they think is the abundance of caution. They said, hey, watch people for 14 days. If within 14 days they still don't have symptoms, we think they're unlikely to develop symptoms. Let's let them kind of go home. So that's kind of one thing to be aware of, is that number is based on that. Next question, how is COVID-19 different from the flu? So we mentioned a couple things. R naught, mortality rate. R naught is higher for COVID-19, 2.3 versus 1.3. Mortality rate for COVID-19, reportedly 3.4%. That's kind of a ceiling, likely lower than that. Flu, quite low compared to that. It's 0.1%. The Spanish flu from 100 years ago had a higher mortality rate. That one was thought to be closer to 2%. Another difference is the burden of disease we have right now. So for COVID-19, it's about 500,000 global deaths. Massive. For COVID-19, globally, we're seeing, again, 3,400 that have died. So 3,400 versus 500,000 is just not even close, right? Two more things. Vaccine. We have a vaccine for the flu shot, 50 to 60% vaccine effectiveness. So I'd say moderately effective, pretty effective. versus for COVID-19, we have no vaccine. We have some that are one that's kind of just starting trials. That's not going to come out till 2021. Treatment we have for flu, oseltamivir, works pretty well. For COVID-19, we have one, again, in clinical trials. This one's phase 3, remdesivir. So remdesivir is being tried out in Nebraska. There are a couple of large trials in China. But again, it's in clinical trials. It has been used for compassionate care use, meaning in one-off cases where someone's really sick, they have used it, and it's been effective. So that's one thing to just be aware of. But again, not kind of available, not easily, not as well understood as oseltamivir. All right, next question. What's the difference between COVID-19 and recent previous outbreaks? Great, so let's talk about those. SARS and MERS are the recent coronavirus outbreaks. SARS affected about 8,000 people. COVID-19 is at 98,000 people, so 10 times, 12 times more. SARS was at 10% mortality rate, and that was at the end of it when we kind of had wrapped up everything and figured out kind of at the end of the day, what do we believe? 10% mortality or thereabout. For COVID-19, it's 3.4%, and as I mentioned earlier, might be lower than that. MERS was actually even more extreme. It affected far fewer people, 2,500 people, whereas the mortality was 34%, so 10 times the mortality rate of COVID-19. So what you're seeing here is that SARS and MERS both affected far fewer people, but were much, much more dangerous in terms of if you got them, the mortality rate was much higher. And one thing to note here is that coronaviruses are going to keep coming through. So bats are the reservoir. There are interactions between bats and other animals, like civet cats and camels for MERS, and then for this one, pangolins. But there are these kind of animals that then transfer them to humans. In other cases, sometimes humans just get them directly from bats too. So this is likely to happen again. And it's happened again twice already in the last, or 3 times now in the last 20 years. It's going to happen again. And we just have to recognize when it starts happening how to quickly squash it so it doesn't kind of explode the way this one has. Next question. What % of people getting this virus will develop serious disease? So a great study came out last week. It said basically 20% get serious disease. Now, again, with what I said earlier, that's in the context of limited testing, right? So as we test more and more and more people, just like the mortality rate's going to fall, this percentage of like serious disease is also going to fall. So 20%, I would say, again, is kind of a ceiling number. It's likely to be much lower. And a lot of that is among the elderly. A lot of that serious disease is happening in the elderly population. Not to say it can't happen in other groups, but that's where it's mostly happening. Where there is an interesting wrinkle, I kind of want to focus your attention on, is where you get a big inoculum, right? So when I say inoculum, what I mean is lots and lots of secretions full of virus versus a little bit of a secretion full of just a little bit of virus. So let's say 2 scenarios. One, I'm trying to intubate, putting a tube down someone's throat so that I can help them breathe. And I'm right in their face. And let's say I'm not wearing my N95 mask because it's soiled or I forgot to put it on or I'm in a rush. And I'm kind of face to face. And that person just kind of coughs or sneezes or gags. And all of a sudden I get in my face kind of a shower of these particles full of virus. That's a large inoculum. Compare that to me being at a conference and me grabbing a handle on a restroom, and maybe someone had forgotten to fully wash their hands and they got some virus on that handle. That's a small inoculum. So these are the 2 different inoculums. What we know from the data is that when you get a large inoculum, you get sicker. And so the people at risk, I mentioned the elderly, but the other group at risk for serious disease are healthcare workers because they're with the sickest patients, and the sickest patients tend to have the highest amounts of virus. So that's just one thing to kind of keep in mind. What should I do if I develop symptoms? So if you develop symptoms and you're, let's say, in the community, and you get a little runny nose, and then all of a sudden 2 days later you're coughing and you have a fever. And again, a fever would be anything 100.4 Fahrenheit or 38 degrees Celsius or higher. So those are the cutoffs. So let's say you get a fever, you're coughing a bit. The first thing to do is self-quarantine. That means stay in your home, protect your household contact. You don't want your significant other, your kids, your parents to get ill as well. That means putting on a surgical mask. That's where the mask is very useful. It's for people that are sick. And make sure that you, at that point, right when you first get sick, you don't run to the hospital or the clinic. That's the last thing you want to do, right? So there's a good chance you might have something else. Maybe you have the flu, and then you go to the hospital, and then you expose yourself to another virus, or maybe you expose yourself to COVID-19. So the last thing you want to do is just immediately run to the hospital. What you want to do is self-quarantine, take care of yourself at home, drink plenty of fluids, watch your hydration status. Are you peeing? Are you coughing more or less? Is the chest pain more or less? Track all this stuff. And if things are going the right way, like you're getting better, great. Good job. That's perfect. That's what we want to see. If it's going the wrong way and you're getting sicker, maybe you're lethargic, you're not feeling well, the cough is just so severe, so much chest pain, that's when you pick up the phone and you call your hospital or your clinic and say, hey, I'd like to talk to a nurse or a doctor to figure out what I should do. At that point, they might say, hey, you know what, why don't you come in, we'll check you out. And when you go in, of course, wear your surgical mask. And if you don't have one, I'm sure that when you get there, they will have one for you. So that's what you should do. What are the various types of masks, and what is the correct way of wearing the mask? All right, so there are two different types of masks that are out there. There's a surgical mask that's just it's got two loops on it. If you're in the general public and you have no symptoms, let's say you feel like me right now, then you should not wear a mask. You don't need to wear a mask. It's really for people with symptoms. So that's pretty simple. The other type of mask, and that's really the only mask you should even be considering. The other type of mask is the N95 mask, and that's a mask that actually prevents things from getting in. The surgical mask prevents things from getting out. So if I'm coughing or sneezing, it catches all that inside the mask. The N95 actually protects things from coming in from the outside. And so to wear it properly, make sure you have a good seal. We're actually going to be dropping a video on this topic pretty soon, so stay tuned for that. And you want to make sure you're clean shaven, so there's no sort of facial hair like I have, so that the mask can sit really nicely and is tested. So if you're a healthcare worker, those N95 masks are for you. If you're in the general public, you should just be wearing the surgical mask only if you're sick. So no need to hoard masks or any of that kind of stuff. Those N95 masks are in short supply in many places, so really need to go to healthcare workers. Next question, why aren't antibodies from the recovered patients not being used as a treatment? It turns out they are. So a pretty cool idea is to say, well, what if you have all these 54,000 people recovered? We know they're forming antibody to COVID-19. Why don't we get that antibody kind of concentrated and give it to people that need it? And in fact, that's what we do. It's called kind of passive immunity. And we give that in many cases. Measles is an example where if you're at high risk, we have measles antibody. Where do you think we get it? We get it from other people that have had measles or vaccine and have an immune response, and we gather that up and we give it to people that need it. We're exploring that. I say we, I'm not exploring anything, but the manufacturers are looking at this as a possible treatment. And so that's not even in FDA at any point in the pipeline yet, but it will be. And so that's one thing to look at. As a side note, they actually looked at breast milk to see if moms with COVID-19 were giving or transmitting the virus to the babies. And it turns out that actually in a series that they looked at, the babies were not getting COVID-19 disease or the virus through the breast milk, but they did detect COVID-19 antibody in breast milk. So actually one more reason to think about breast milk as a good thing is that in that scenario, they were seeing that the breast milk had the antibody, and that was thought to be passive immunity for the baby. So that was a pretty cool thing. Next question. Are there any updates about the vaccine for the virus? So pretty interesting updates for sure. So there's a company called Moderna. Moderna has an mRNA vaccine that's out there. And the way it works is, and when I say it's out there, let me rephrase, it's out there in studies. And so it's still in phase 1. That vaccine will not be ready until 2021. So let's be very clear on that. And so for you and I to get this vaccine, we're looking at next calendar year. But Moderna has this vaccine. It's in phase 1. It's an mRNA vaccine, and the way it works is the RNA gets injected into the cells. These cells, like if it's my hand, kind of pick up the mRNA. The mRNA is inside this cell, the antigen-presenting cell. It then transcribes and translates this into a protein. That protein sits on the surface, and then that protein is causing this immune response. So it's a great way to get an immune response out of someone. It's a vaccine that works in a very elegant way, and it's kind of a relatively new technology. Again, still in phase 1. There are other types of vaccines out there that are being looked at, but they're not even at phase 1 yet. So this is kind of the one that's furthest along. Next question. What methods are used to diagnose the virus? What are the clinical laboratory criteria to suspect the virus? So again, put your heads in the shoes of, let's say I'm in the ER and I'm told there's a patient that just called in, they're feeling sick, they're now headed this way. First thing I would do, make sure I go out to the parking lot, hand them a surgical mask, and make sure that they don't just walk around the ER exposing people. That would be a nightmare scenario, right? Second thing, I make sure I myself am protected, right? So I've got my N95, my eye protection, contact gloves, everything. And I go out there and look and make sure that they're safe. So I bring them in, and then I want to check their vital signs. Are they severely sick or not? And the clues there are the respiratory rate, the fever. I want to make sure I immediately do things like send off a rapid flu test. It's still flu season right now, right? It's March. So we're in the middle of flu season. The most likely thing someone has is the flu or one of the other viruses. It could be adenovirus, it could be RSV, rhinovirus, any of those. I also want to make sure I send off like a viral panel if my hospital has that. I want to get a chest x-ray if I'm concerned, maybe even a chest CT. And chest CT is actually one thing I want to kind of focus on here. There's evidence that chest CT in this context is very sensitive and more sensitive than PCR. In fact, we're going to drop a video about this topic very soon, so stay tuned for that. But basically, in this context, chest CT has a sensitivity in an endemic setting. So actually, let's say we're in China, in an endemic setting, the sensitivity is above 95%. You're missing just maybe 1 in 20. By comparison, PCR has a sensitivity of 30 to 70%. That's much, much lower and very concerning, right? Because in that setting, you're missing out of 100, 30 to 70 people, you're missing them. And when you miss them, you might be sending them out back in the community to get sicker, which is really worrisome because there are treatments, like I mentioned. And also, they're exposing more people. So again, we're not doing our job in terms of combating that R naught factor. We're really kind of causing that transmissibility to really ramp up. So that's the worry with missing people, which is PCR. So chest CT is a great modality. It's been shown in a number of studies now to be effective and much more effective at picking it up early on. So take a look at that video. It's all about how to read chest CTs to look for those findings. Other things you would do, CBC, blood culture, and then ultimately, of course, you'd want to, if you're suspecting it, you want to send off a respiratory blood PCR for COVID-19. You'd want to detect it if you can. So that's out there. And you want to, of course, make sure that your laboratory can do that and supports you. What's the risk to healthcare workers? Next question. In endemic settings like China, 15% of healthcare workers got really ill, went to the ICU, some of them died. That is very, very worrisome, right? Because if 15% are getting sick, that means your healthcare workforce is either A, going to be panicked and they won't want to come to work, right? That's terrible. They might go on strike like some people did in Hong Kong and say, we're not going to go to work until you get us proper PPE, the personal protective equipment, and only then will we come to work. Or you simply have to quarantine people and say, look, we've got so many exposures here. We have to quarantine half our staff to see who's really, got sick and who isn't. And if you're quarantining half your staff, you don't have much staff left. So this was really concerning when I saw this. 15% is a really worrisome number. And I think we should all focus on this number more than anything else because we need to make sure our healthcare workers are safe through this process. If they're not safe, none of us are safe. And you don't want a scenario where N95 masks are getting hoarded by regular folks that don't need them and healthcare workers don't have them. So we have to make sure that they get properly supplied in those settings so that we have a hospital that's staffed with the right people, nurses, physicians, respiratory therapists, et cetera. The risk factors for why this number was so high, 15%, was they didn't have the PPE, but also they were fatigued. They were working double shifts. They were falling asleep. They were unable to kind of care for themselves like they needed to prevent the virus from getting in. And that's something that we have to look out for too, is fatigue that sets in as we start stretching our healthcare workforce through kind of out. So what are things that healthcare providers can do to prepare? Know the phone number of your Department of Public Health. Talk to them, call them, understand what their protocols are. Understand what your hospital protocols are. Do you understand what rooms in the hospital are positive pressure versus negative pressure? For example, many ORs, operating rooms, are positive pressure. If you go in there with a COVID-19 patient because you're concerned they have some abdominal pain, you're actually exposing a lot of people because that positive pressure is moving the virus out of that person's kind of mouth and into the room and into other people. So that's a dangerous scenario. You need to find out if you can order RT-PCR. Many states in the US actually, believe it or not, still to date have not done any PCR testing. So we need to make sure if that's possible, how you do that, what paperwork you fill out, et cetera. And then again, I mentioned chest CT. Learn the classic chest CT findings. It's better than RT-PCR in early disease in that high endemic setting. And so learn the findings. And we have a video specifically about that. So if you're on the front lines, you should definitely check that out. Next question, what can I do as an intern to protect myself? I mentioned some of this, wearing PPE the right way, making sure you don't have facial hair if you're wearing an N95, washing your hands, taking breaks. And then if you are starting to feel ill, quarantine yourself. The last thing you want to do is keep working and exposing others. And also you don't want to expose yourself to a secondary inoculum, right? You don't want to get more of the virus if you already are trying to combat the virus. So making sure you quarantine yourself and stay safe. A couple more questions I'm going to answer because I realize we're getting at the end of this. How long can it survive without the host? The virus can survive and transmit for hours up to a day on a non-porous fomite. So something like, let's say, a cell phone, a doorknob. These are non-porous fomites. Up to a day can survive and transmit. There are special cleaners that the EPA has mentioned. A couple days ago, they sent a list out for what you should be using in your hospital or really anywhere to clean these surfaces so that you're not transmitting them. And final question, this has come up a lot in terms of the effect of heat on the virus. As the summer months approach, as we get into kind of April through, let's say, even November, these are the low months for coronavirus normally. Coronavirus typically peaks December through March. It's because the viruses prefer kind of cooler, drier environments rather than warmer, more humid environments. Having said that, that's for coronaviruses normally. We don't know for COVID-19 if that's going to be the case. And in the past, when we've seen this, going back to like the Spanish flu, what we saw is that there was a kind of a diminishing of the virus, but then it resurged late. And we saw hundreds of thousands of people affected in that resurgence. So by no means, if let's say this ends up going down a little bit in April or May, we should not be doing a victory lap. Instead, we should be thinking about the fact that this may be just kind of endemically circulating and then going to resurge, especially because this is hemispheric, right? So what's winter in one hemisphere of the planet is, the summer of the other hemisphere. So this could just kind of bounce back and forth a bit, causing worse disease in some areas and maybe less disease in other areas. So I'll end there. What I will say is this is an evolving situation. We want to have your backs and give you the best information. There are a lot of different stakeholders here with lots of different questions. I do want to say that if you have questions that weren't answered, put them in social media. We will definitely kind of go through them. I'll go through them, answering all those questions as best we can. We might even do one of these again. But we want to thank you for participating and spreading good information. And most of all, go out there and don't overreact, don't underreact, but just kind of react as appropriately as possible. And on that note, be well. Thank you.